Mark Bogula. Um, Dr. Mark is the endodontist in Arabic clinical practice. He is also clinical instructor in endodontics at the University of Melbourne. Chúng ta bắt đầu buổi chiều hôm nay thì cái báo cáo đầu tiên là thầy Mark Bogula. Thầy là một cái nội gia học của cái thực hành lâm sàng. Thầy cũng là một cái giảng viên trong lĩnh vực nội nha ở đại học Melbourne. Một lần nữa thay mặt cho ban tổ chức xin trân trọng giới thiệu đến tất cả hội viên thầy bác sĩ Mark Bogula. Thank you.
Thank you very much for that introduction. As they said in the introduction, my name is Luke. I'm an endodontist in Melbourne. Most of my work is predominantly in private practice. I've been working in private practice for roughly 20 years. I've also been involved with teaching both undergraduates and postgraduates at the University of Melbourne during that time. In continuing with what everyone else has been talking about, my lecture topic is going to be tips on successful outcomes in endodontics. Before I start, this is my third trip to Vietnam, and I'd like to say a big thank you to our hosts for their hospitality and warm welcome that they have extended to us. We've really enjoyed our time here in Vietnam. So I want to start by talking about advances in endodontics over the last 30 years. When I look at the things that I include in my practice and what is considered to be standard endodontic practice these days, these are the things that I usually include in my practice. We've had advances in apex locators in helping determine working length. We've had operating microscopes introduced into the industry. We've had advances in imaging, as well as cleaning and disinfecting root canal systems. And while all these advances are well and good, the question we probably should be asking ourselves is, what impact do these advances have on us being able to provide successful treatment for our patients? And also, do these advances actually help us treat our patients' teeth in order to be able to maintain those teeth for ideally their lives? So let's have a quick look at some of these advances. So apex locators are fantastic. It's pretty much the gold standard for determining where we have to instrument and clean root canal systems to. The problem with radiographs is that radiographs are not always easy to interpret. So particularly posterior teeth, where anatomy can become an issue, the bone in that area can be quite thick. Trying to determine working length based on a radiograph is sometimes impossible. Apex locators are very accurate in those circumstances, provided that they're used appropriately and effectively. Apex locators also help us in determining working length in root canals that are quite complex sometimes, particularly when we might have resorptive defects, C-shaped canals that can be difficult to visualize radiographically. They do help us reduce exposure to radiation by minimizing radiographs. I would say that for most of my patients, if I can get a good electronic apex locator reading for working length, I generally won't take a working length radiograph. So we definitely can minimize the number of radiographs we take for our patients. It gives the operator real-time feedback, and it does improve our clinical efficiency. It makes things much faster. More than 40 years ago, Dr. Gary Carr introduced microscopes to endodontics. Now, essentially, you can only treat what you can see, and magnification of any kind greatly improves our ability to manage our patients' teeth. And microscopes open up a whole new world. You're able to see so much more accurately inside a tooth. I mean, the inside of a tooth is very dark, very difficult to see what you're doing without any sort of direct light or magnification. So magnification has made a really big difference in locating canals like the MV2 canal in this particular case, in managing teeth with complex anatomy, looking for isthmuses and variations inside the teeth when you're treating them. It also helps us to decide which teeth we can and can't treat, in particular when when it comes to identifying cracks. It also allows us to manage procedural problems such as perforations and removing fractured instruments if they need to be removed. Microscopes have also led to some big advances in surgical endodontics. Now that we can see a lot better, we can have micro instruments which then allow us to manage teeth surgically much more efficiently and accurately compared to what we used to do without magnification. Next, in the 1990s came advances in metals. So most endodontic instruments prior to the 1990s were stainless steel instruments. But with the development of nickel titanium, which has both super elasticity and shape memory, Ben Johnson introduced the profile instrument, which was one of the very first rotary nitinol instruments introduced into endodontics. And over the years, over the last 30 years, we've had some advances, and I'll talk about those in a second. But the main benefits of rotary nitinol instruments is that they're able to manage curved canals a lot better than we were with stainless steel instruments, which were more rigid. By being more flexible, they maintain the original shape of the root canal system. So you're not transporting, you're not ledging, you're able to disinfect those canals a lot better. So most of the time we're going to have a lot less procedural errors like ledges and transportations by using these instruments compared to hand instrumenting canals. And essentially it does improve our efficiency. So not only are we more efficient and faster at managing our patients, but the quality of treatment that we can provide is generally higher. About 20 years ago, cone beams came into endodontic practice. Now, cone beams did what the microscope did for us in order to be able to see the crown. So now not only can we see inside the tooth with a microscope, cone beams gives us a three-dimensional image of the tooth, which helps us with our treatment planning. It helps us with our case selection, which patients we can and can't treat, or at least it allows us to discuss with our patients difficulties that we might have when it comes to managing their specific problem. So we have, a lot better detection of pathology. For example, in this case here, you can see it's very difficult to see pathology related to that upper second molar, but on a cone beam, it's much easier to detect that pathology. So there's a lot more, but there's a lot less diagnostic uncertainty, where sometimes you might have a situation where a patient comes in with pain, and you think there might be some pathology, and on a radiograph, you can't detect anything. A cone beam will definitely help us improve with that. It helps us with our treatment planning, and it helps us with managing complex anatomy and with surgical endodontics. Bioceramics have been around with us for quite a long time, particularly since about the early 2000s when Tora Binajad came up with or discovered MTA, which we're all very familiar with, and it's part of mainstream dentistry, and more recently with bioceramic sealers. The main benefits of MTA is that it's a very bioactive, biocompatible material that offers an excellent seal. And it allows us to manage situations that were much more difficult to manage in the past with previous materials, like managing perforations, dealing with open apex scenarios, maintaining vitality in teeth with vital pulp therapy, which we're going to hear about later from Sonny, and again with surgical endodontics. If we fast forward a few more years, we've also had advances in the instruments that were introduced in the 1990s. So we've had variations in instrument design. One of the big issues with rotary instruments is that they can sometimes fracture, particularly if they're used incorrectly. So, novel designs which created offset instruments that had less contact with the canal wall and created less friction, thereby reducing the risk of fracture. We've had various novel heat treatments that came up with memory wire and controlled memory wire. A lot of those heat treatments make the instruments much more resistant to fracture, and they make them much more flexible. Things like the high-flex instruments that are processed by electric discharge machining are very, very flexible instruments and very strong instruments. And I can say that, the high-flex that I've been using for many years now, I haven't broken one yet. And I use them in quite large sizes, which are 50 or 60 apical size. So, improvements in rotary instruments have really led to instruments that are much more flexible and much stronger and less likely to fracture in the patient's teeth. The other advances we've had with instruments is that we've had the invention of one-file systems, so you don't need a series of files to be able to treat a tooth, but you can choose a file that might be a small, a medium, or a large file for that particular tooth that you're trying to treat. I'm a big fan of these VT files, which are much more conservative than some of the older designs. The benefits of these files is that they're much more conservative coronally, which you can see in this particular situation here where, you know, the MB2 canal has been missed. The previous dentist treated the main mesiobuccal canal, and you can see that this preparation, which is essentially the same size as that apically, has preserved a lot more of that coronal dentine. And the benefit, I guess, that we have in preserving dentine is that potentially we reduce the risk of those teeth fracturing, and those teeth are able to be maintained for much longer. Other developments that we've had with rotary NiTi instruments are the way that they work. So originally, rotary NiTi would just spin in one direction, whereas reciprocation was introduced where the instrument works clockwise and then counterclockwise. And the benefit of that is that it's supposed to allow instruments to manage more curved canals and reduce the friction on the instrument, thereby reducing the risk of fracture. Other instruments like the FKG instruments, which are the shaper and the finisher file, they have a controlled memory NiTi file that is curved to a particular shape. I particularly like these finishing files because it allows the instrument to clean areas that your traditional rotary nickel titanium files won't clean. On top of using instruments to mechanically clean teeth, we also have to disinfect those teeth with various chemicals. And we've had active irrigation in various forms for a long time. And this is something that I would recommend for anyone trying to do endodontics or doing endodontics for their patients is irrigation alone or passive irrigation is generally not enough, and having some form of activation will improve our chemomechanical disinfection of the tooth. Whether you're using an activator, which is generally a low frequency device, you know, when they came out, that was the one thing that I had, and clearly under a microscope you could see the difference in the cleaning of the canal that you had before and after you used that. We've had an improvement with that with this Eddy instrument, which is a much higher frequency. It's essentially a plastic cannula that's inserted into the canal, and it vibrates at a high frequency range, and that activates the disinfectant and disperses it within the root canal system. We've got passive ultrasonic irrigation that's available to us, and then more recently laser activated activation irrigation, which essentially is just the same thing but a lot more expensive. And so when we look at all these advances in technology and what we use to treat our patients, it's not unreasonable to expect these sorts of success rates for our patients when we're undertaking endodontic therapy. There are clear differences, and one of them obviously is infection at the time of treatment. So teeth that are not infected, that might be inflamed, will generally have a much higher success rate, or higher success rates than teeth that are infected. And certainly teeth that we're redoing treatment for may have a lower success rate as well because of the obstacles and the challenges that are associated with retreatment. But generally speaking, we can achieve quite high success rates. I guess the question we should be asking is that how do these success rates compare to what endodontists used to do in the 1990s or the 1980s? And that's probably the more important question. So when we look at from 1960 to roughly 2000, there were a couple of landmark key papers that really changed the way we view endodontics. And the first one was in 1964 by Takahashi. He had two groups of rats. One group of rats were genetically modified not to have bacteria in their mouths, and the other group was conventional rats. And what they did was they basically cut the teeth open to expose the pulps in those rats. And what they found was that the rats that had no bacteria in their mouth didn't develop apical periodontitis, and in fact they had a regeneration of the dentine, whereas the conventional rats developed pathology or infection. And this was further sort of supported by Sundquist in '76, where they found that teeth with apical periodontitis contained bacteria, whereas necrotic teeth that were not infected had no bacteria in them. So one of the sort of take-home messages from that was the importance of bacteria in the development of apical periodontitis. Next came Beestrom and Sundquist in the 80s, where they did a series of papers where they looked at mechanical and chemomechanical disinfection of root canal systems. And what they did was they sampled teeth before treating them, after mechanically instrumenting them, after irrigation, and later on after medication. And what they found was that bacteria, or removing bacteria from pulps and root canal anatomy, was important for success rates. So if there was bacteria that were left within the root canal system, then the chances of that treatment failing was higher than teeth where they couldn't culture bacteria. In the 90s, we had a series of papers by Sjogren who looked at outcomes of treatment, and the same sort of thing. They looked at factors that affect the outcome of treatment and where we should be cleaning teeth too. But they also looked at the importance of infection at the time of root filling. So they sampled teeth after their chemomechanical preparation, and they followed those teeth up to see whether the outcome was successful or not. And in the teeth where they were able to sample bacteria, the success rates were significantly lower than in teeth where they couldn't culture bacteria. Moving on from there, in the 90s as well, we had a series of studies by Ramachandran and Nair, and he looked at histology of pathology, basically. So he was able to conclude that the main cause of persistent pathology was bacteria within teeth, and was able to sort of show the complex anatomy, the various role of biofilms, apical deltas, areas that were very difficult to disinfect, and they concluded that the majority of lesions or persistent lesions were as a result of remaining biofilm within the root canal system. And other causes of failure, like bacteria outside the root canal system or cysts, actually only formed a small percentage of persistent pathology. Orstovic in 1990 also showed that bacteria can penetrate into dentin tubers, which makes disinfection much harder. I don't know if this image comes up very well, but this was the root filling that was removed from that tooth, and it was just completely covered in biofilm, what you might see when you clean a pipe under your sink. And that's sort of the thing that we're dealing with when it comes to infections in teeth. One of the last papers that I want to sort of talk about is Ray and Trope in 1995. Now, it's a little bit controversial, but the main finding, or the main thing that they concluded from that paper, was that the way we seal teeth, whether it's during treatment or after treatment, is just as important as the treatment we do to try and disinfect the space in the tooth. So they found that patients who had good quality root canal treatment and a good restoration had the highest success rates. They found that when you had poor root canal treatment and poor restoration, you had a poor success rate. But they're finding here where they found that a good restoration was almost more important than a good root canal was controversial, but it did sort of undermine it, or what's the word I'm looking for? It made us understand the importance of a good restoration. There's no point in doing good root canal treatment but then sealing the tooth poorly and allowing leakage to occur. So the three sort of key findings from those papers, those landmark papers that really changed how we look at endodontics, is that bacteria are essential for not only pulp necrosis but the development of apical periodontitis. And if we want a formula for successful treatment, we have to consider these three things: using an aseptic technique, disinfection being the central goal of our treatment, and also preventing bacteria getting into the tooth, so how we're going to restore that tooth afterwards. And interestingly, if we look at the success rates that were published in a lot of the literature back from the 80s to the 90s, the success rates don't differ that much. So these days we have all this great technology to help us manage teeth, but the differences are really 5 to 10%. Probably the biggest difference that we're finding is either in retreatment or apical surgery. So what did they do back then that made their success rate so good? Well, the first thing is an aseptic technique. And I've translated this because I really want this message to get through. Nowadays the international standard, and it's been like this for a long time, is that rubber dam is mandatory for all treatment. If a patient can't manage rubber dam, there's no negotiation. We don't do root canal treatment for that patient. We feel it's so important in trying to maintain an aseptic field when we're doing treatment. And not only do we use root canal treatment, use the rubber dam at the start of treatment, but for every phase of the treatment. The rubber dam doesn't come off until the root canal system is sealed, whether it's temporarily or permanently. One of the things that I often hear when I talk to dentists in Australia is that rubber dam takes too long, rubber dam is too difficult, patients don't tolerate rubber dam. I'll share this video with you, just showing how quick rubber dam placement can be and how easy it can be. This whole process takes, for me, 45 seconds. And that would be typical for every patient that we're treating. It is not a long process. Once you start using rubber dam and using it routinely, like anything you do in dentistry, it becomes much faster. And the time that you take to put rubber dam on, you'll save in other ways throughout your treatment. A lot of the time, we chase all the new technology. We like to have all the latest and the greatest things. And lasers and microscopes are all fancy, and the best rotary nickel titanium instruments. A lot of these things are more expensive than the basics. And the reality is, if we do the basics right, they're an inexpensive way to get good outcomes for our patients. So the things we really need to understand is, this is the problem we have when we're managing root canals. We're never going to get 100% success rates, and the reality is that when we look at root canal systems, they're very complex systems. So here's an example of a micro-CT of a tooth before it's been prepared and cleaned, and here it is afterwards. We're only cleaning about 40% of the inside of the tooth with our mechanical instruments. This is why we rely heavily on our irrigation protocols, because it's really irrigation that helps with the disinfection. But even with irrigation, it's not going to get into all those areas, which is why we use the activation. We do use hypochlorite and EDTA as standard practice for every patient. Saline is not going to be enough to disinfect a tooth. You could use chlorhexidine as an alternative, but generally hypochlorite's the standard. There's a lot of evidence to say that calcium hydroxide medication does further reduce bacteria. And if bacteria are the cause of persistent disease, then medicating is usually a good idea. Although it's debatable, you can still do treatment in a single visit provided you do it correctly. And most importantly, coronal seal. Not only coronal seal before treatment, after treatment, but also before and during treatment. So this is one of the things that, again, we see a lot happening in Australia, where patients are referred like this, and the patient's there because they can't control the pathology. So either there's persistent pain, persistent infection, and they're wondering why, because they've cleaned the tooth a number of times. The reality in this situation is that there's caries there, there's leakage. And when dentists often temporize these teeth, they put in a cotton pallet and a temporary restoration coronally, but there's leakage under the restoration. So we have to make sure we remove all the caries. We provide a good seal during the treatment, like a well that allows the disinfectant to sit within the access cavity, and then temporize it well afterwards. And here's another case demonstrating the same thing that was referred to my practice, where the temporary restoration was poor, and in this case we had to temporize it with an orthodontic ring. So just to summarise those, I just want to share these two cases with you. This was a sort of 40-year-old female patient that came into my practice, and she had pain and swelling relating to that tooth. And I was really pessimistic about that. I actually told the patient, listen, I think you probably should take that tooth out. I don't think it's going to heal. And she's like, no, Luke, let's have a go. Let's see what's going on. And so I took the restoration out, and you can see the caries underneath and the leakage, which you can't see on the radiograph. And after a period of 6 months of medication, I was surprised to get the patient back and see that the lesion has healed. So it just demonstrates, if we can manage the problem, which is caries or leakage causing infection of the root canal system, and we can follow all the steps through to completion, we can achieve quite good outcomes. This was another patient that was referred to me by an oral surgeon. The oral surgeon had the patient in their office because the dentist wanted to remove these 2 teeth because they diagnosed a periapical cyst. And the surgeon sent it to me going, listen, what do you think, Luke? Is there anything we can do with the root canals? Could this be just an endodontic problem? So I said to the patient, let's go and get a cone beam and have a look. And you can see the cone beam shows the area of infection. It extends from tooth, the first premolar all the way through to the second molar. But more importantly, it shows the presence of an untreated canal levomesia buccal root. And so I said to the patient, listen, there's an untreated root in this tooth. Let's just go into the tooth and retreat this tooth and see what happens. And again, to my surprise, the patient came back and the whole lesion had healed. No surgery, just managing the problem, which was the untreated tooth. So, in summary, the message I want to get across is that fundamentally endodontics is biology-based. It's an infection control procedure. It's not a mechanical procedure, which is a lot of the time what we focus on. We focus on the mechanics, what instrument systems we're using, which instruments are the best, rather than focusing on we need to disinfect this tooth. We need to remember and keep in mind that instrumentation shapes the canal, but it's the disinfection that determines success and outcome. And we need to focus on technique. So focus on things that we can do better, the basics that we can do better, whether it's placing rubber dam, whether it's removing decay, managing temporary restorations. Focus on the technique. They're not the equipment or the instruments or the materials. Thank you very much.
Thank you, Dr. Gula, for your interesting presentation. Now please welcome to stage Associate Professor of